In elderly type 2 diabetics with cognitive impairment, the treatment regimen has to be simplified and the targets have to be relaxed to improve the compliance. Similarly, in elderly type 2 diabetics with history of falls, you should try to avoid sedative drugs, antihypertensives with potential for postural hypotension, and the anti-diabetic agents with the potential to severe hypoglycemia. Once the geriatric assessment and the nutritional assessment is over, the targets and the therapeutic regimens can be fixed based on the patient needs, preferences and risks. In healthy elderly type 2 diabetics, the A1C target would be 7 to 7.5, whereas in a frail elderly diabetic, if the life expectancy is 10 to 15 years, it would be prudent to have an A1C target of 8%, and if the life expectancy is less than 5 years, it would be 9%. Having said that, like in the other populations, diabetic populations, it is not only glucose centric, it is a multifactorial risk reduction. Therefore, all diabetics, if they have blood pressure, it should be treated to 140/90, and in patients with increased cardiovascular risk, it should be titrated to 130/80. Similarly, the management of dyslipidemia, if an elderly type 2 diabetic patient has ASCVD, he will have an high intensity statin therapy. If the elderly type 2 diabetic has only risk factors for the atherosclerotic cardiovascular disease, he would be on moderate intensity statin therapy. And regarding the use of aspirin, it has no role in primary prevention of the elderly because of the bleeding risk. Whereas in the secondary prevention, a low dose aspirin 75 to 162 milligram can be used in elderly type 2 diabetics if the 10-year ASCVD risk is more than 10%, or if they already have an atherosclerotic cardiovascular disease. But in the management of type 2 diabetes, nutrition, that is the lifestyle modification, is the cornerstone of therapy, whether you prevent diabetes in elderly pre-diabetics or treat diabetics. Once they are not in the target range with the lifestyle modification, that is the nutrition therapy and the physical activity, then you should not go for a restrictive diet in the case of elderly type 2 diabetics, because they are already at risk of malnutrition with sarcopenia. They should be given a high protein diet which is rich in energy, but try to avoid direct sugars. If the lifestyle modification does not produce the desired results to be in the target range, then we should design therapeutic regimens with low potential for hypoglycemia. Encourage use of metformin if there is no GI intolerance or contraindication. Encourage the use of alpha glucosidase inhibitors if there is no GI intolerance, or SGLT2 inhibitors if there is no risk of volume depletion and hypotension. And if you have to use the insulinotropic agents, then the choice would be glucose based insulinotropic agents, that is the agent which will release sugar only when the glucose levels are high. They are the meglitinides and the DPP4 inhibitors. But if you have no choice and have to use a more powerful insulinotropic agent to achieve the target A1C and the blood sugars, then among the sulfonylureas you can use a short acting glipizide or the insulin sparing sulfonylurea glimepiride. And the insulin. Insulin is the most potent anti-diabetic drug, and if you have to use insulin in the elderly diabetics, if it is affordable, go in for insulin analogs, both short acting, which is the flexibility of administering immediately after a meal, since the food intake is not consistent in the elderly population, and the long acting basal insulin analog to avoid the nocturnal hypoglycemia. And the best treatment option with insulin is the OD basal insulin, along with the oral drugs that does not require insulin for control, or a basal plus to cover the largest meal of the day. To summarize, type 2 diabetes incidence the highest in the age group 65 to 74, contributing to the diabetes epidemic, at least in the developed world. The main defect is beta cell function, and the abnormality is postprandial hyperglycemia. They do not present with the usual symptoms of diabetes, but have atypical symptoms, heterogeneity in the clinical features, pathophysiology, and the development of complications, high degree of cognitive impairment, hypoglycemia unawareness, increases of HNKC in the elderly type 2 diabetics. And in the treatment part, avoid restrictive diets, and in the drugs, use drugs with minimal hypoglycemic potential. Last but not the least is diabetes education to self-manage, diabetes education to the patient, the caregiver, and also the primary care physician. Thank you.